what we try to do is basically make affordable medical devices for everybody. And our aim in the lab is we believe everybody should have the ability to make their own health and wellness technology. We've democratized lots of different sectors. We've democratized cooking. We've democratized flying robots. Why not health? And when we look at thank you. And so when we look at our own research and try to analyze this, I'll give you a few examples of health and DIY coming together. So usually I tell our students, and we filter them out based on how excited they are by an example like this. The man on the left that you see over there, and the gadget on the bottom left, is a man in China who was told that he had to have long-term dialysis and he couldn't afford it. So instead of taking it lying down, he said, I'm just going to make my own dialysis machine. And he's in China. He just basically assembled all the parts that he could and made his own dialysis machine. And 6 years later, he was alive and well. And then, of course, the BBC found out about it, made a big show about it. And now he has a full scholarship from the Chinese Ministry of Health for a regular dialysis machine. But it tells us that in case of extreme circumstances, in extreme health circumstances, you're going to find extreme ingenuity. Now that's in a very hard situation, but who's heard of balloon angioplasty? Okay, wow, a lot of people. So that's something that Medicare pays for every day. It's an everyday routine procedure that a cardiologist does. And if we fly back to 1976 and go to Switzerland, what you see over here in the middle is the apartment kitchen of Dr. Andreas Grunzig, who started and invented the concept of balloon angioplasty. And he didn't have access to a lab. This is Switzerland. It's a country where they probably make the most amazing flying robots. So we don't have any lack of engineers. I don't think they have any problem with cash. But he just was simply out of the loop. But so he basically DIY'd a whole new field of medicine and then tried it on somebody, got permission from his hospital after hacking together between 11 p.m. and 3 a.m. in the morning with his neighbors, and went on to lead Emory University's balloon angioplasty program, which launched the field. And then in the right is one of our own maker nurses, in this case in Nicaragua, basically going to a toy store, figuring out, looking at different items that she wanted to make. In this case, she wanted to make an IV alarm, and essentially just did it. So for us, these are small little glimpses that DIY has been with us before. It's launched companies like Cook Medical and Medtronic and lots of other mainstays of today's medical technologies, and we want to bring it back and get all makers involved in healthcare. So this is our general mashup that we're trying to do. Now, one of the problems in health in particular is that, and in technology in general, is that we have this fascination for things that are magical. And I can tell you that, and I like the way Arthur C. Clarke puts it, which is any sufficiently advanced technology is indistinguishable from magic. It's got to be like the iPhone. It's got to be, you don't really know. Makers are different. We want to know how it works. We want to tear it up and open it up and understand. But if you walk to a doctor's office or any healthcare, you have lots of these black boxes that we don't know how they work. They happen to be often white and off beige, but they're generally black box design. And so what we do in the lab is we go in and do technology teardowns and say, this is how it works. This is a handheld cauterizer pen sold for usually between $15 and $25. And our doctors in the field would often tell us, they stop working. We don't know why they just stop working after around 7 days. And I thought, well, I don't know. You know, I've never really used one. We bought one. I played with one, and indeed, it stopped. It basically, the very tip of it, it's kind of like it looks like a pen, glows very hot, and it cuts, and it cauterizes as it cuts. And I thought when I was going to tear it open, we were going to find who uses a Live Scribe pen here? I don't know if you've seen those fancy pens that have a computer and all sorts of electronics. And I thought, this is what I'm going to find. And instead I found 7-Eleven electronic flashlight complexity. You know, I mean, the only reason it runs out is the batteries die. So why can't we make one with a replacement battery? But it's this black box mentality that is pervasive in all of biomedical design. And again, we're trying to push back. There are social structures. Everybody thinks that it's Dr. House that's going to be the one coming up with all the ideas, and she's going to, the nurse on the right-hand side is just the one that's going to care for the patient and just abide by the innovation of the doctor. And that's something we see often. The social, it's often less about the technology, it's often about the social dynamic. But what history tells us over the last 100 years is that nurses have been probably the primary hackers and makers of the unit. In the main, nurses have a main academic journal. And if you're a nurse, you get it for free, called the American Journal of Nursing. And at the beginning of the century, Anna Young did some research and found that we basically had, within the journal, the equivalent of Make magazine how-tos for nurses and by nurses. People would submit their ideas and show different things that they had done. And so after about 1950, it just sort of died down. And we don't know why. That's why part of why we launched MakerNurse. We want to find out what happened to all the nurses. What we know is that they haven't stopped. We know that they've just gone stealth, which is fascinating for us because we study a lot of lead user theory and how makers are the primary inventors. But in this case, we have a whole field and a whole profession that is stealth making. So we talked to the Robert Wood Johnson Foundation, and they reached out to us and said, could you do what you've done in places like Nicaragua and other places, but work with nurses in America? And we all agreed that nurses were creative, they were inventive, they are prototyping, and wherever you see a nurse, there's the possibility and the potential for innovation. So let me give you some examples of this. So in the American Journal of Nursing, people were just submitting things like how to keep syringe parts together. These are the days where you had like glass syringes, so keeping a syringe was a big deal. You just didn't throw it away. And they would send basically an entire how-tos in just little short snippets, as you say. They say, well, I worked with the electrician here, I worked with somebody else, or I made it on my own. This is a organizer so that you can autoclave your instruments. And there were all sorts of things, how to make colored casts. And when we were uncovering all these articles, it just our imagination went wild. It was like, wow, imagine if they had Sugru. Imagine if these nurses had access to 3D printing and all these other prototyping tools. So in large part, that's how we organized our project. We said we want to go around the country and find out what materials you're using. Because it's not the same type of materials that I'm going to be using at MIT or a maker at a local makerspace is going to be using. What is the ecosystem around this? How are they sharing information? And who are they sharing it with? How are you being recognized for this type of activity? Does it go on your end of year report from your employee? Do you get a medal at the end of the how are we finding out how does your local workplace recognize this? And because to make things a little bit easier, where are you? Are they clustered in different areas? And so far we're still finding out a lot more of this, but we thought that we'd do a check-in with you to let you know what we've discovered. And as I mentioned, we're flying around the country. We've logged over 45,000 miles in 6 months. Our frequent flyer miles accounts have like ballooned, which is awesome. We have gone to maker fairs and figure out ways to engage them. We brought nurses to, I don't know if you saw us in the different buildings yesterday. We did MakerNurse tours where we would go and bring nurses and then show them a curated version of Maker Faire so that they would have a better sense of what tools would be good for them. And then we've engaged and are trying to create communities and tools with all the information that we gather so that they can continue to do more of what they're already doing, but do it better. And we want to underscore that. Our lab is in the business of creating tools. We get a lot more excited when somebody else calls us and says, this is what I'm making with the types of instruments that you've created. We're not in the business of looking out for problems and ideas that they bring to us and solving them, because we feel that we want nurses to own more of the solution, not just own more of the problem, which is right now what usually happens. So what materials are they using? Let me give you a sneak peek of the things that we're learning. They generally have a closed supply chain. This is their hackerspace. They have a closet, and it's full of supplies if you're in the hospital. If you're a visiting nurse, they basically carry it with them, and they have a little bit more flexibility or more constraints depending on how you view it. But what hospital supply closet does is that it creates a closed system. So somebody approves which materials get bought, and then they basically make within those materials. Sometimes it's pretty creative, sometimes it's pretty wasteful. They don't have things like they don't have the fancy fasteners that we have access to. They don't have zip ties. So they end up sometimes using these $5 materials simply to attach something to an IV stand. So those are the types of things that we're learning. We had no idea how much tubing they deal with every day. If you know, every time we get emails every week from all over the country, and it seems like an enormous amount of them have to do with some sort of tubing or IV innovation, which makes sense. You know, patient, you go in, you get a drip, or you know, something goes in, something goes out. That's the way the body works. And they're just masters at pneumatics of all sorts. You know, liquids, airways, splitters, valves. We work on another part of our lab. We work with microfluidics and lots of fancy valving. We've never seen anything like what we see nurses do with tubing. They don't really use electronics in the same way we would consider electronics. You know, there is no Arduino for the nursing unit. There is no notion of taking control of it, because most of the electronics that they will interface are either digital, like electronic medical records and that sort of thing. And we make it very clear that's not an area that we're trying to work with, because that's more process. Or they're black box. It's just a display that you're reading, and it's generally proprietary, which means that you can't download the data, that you can't mash it up, you can't combine it with there's a whole challenge of interoperability between instruments. So there was really no notion, and that's the types of things that we're trying to inject when we bring them to Maker Faire and create tools, is say, hey, you know, it's not a big deal if you can broadcast this display from a pulse oximeter and send it to an if this and that system using a Raspberry Pi. What we try to do is try to demystify those systems so that they get a little bit more comfortable with, but there is nothing there. There is, however, a lot of advanced material science that we've learned from, for instance, wound care nurses and nurses that work in recovery units. And what we found fascinating is that we had no idea that this concept of wound care nurse, it's a whole field. It's basically, if you have a pretty bad wound, there's a whole sector of wound care nurses. They make bandages, they make dressings, and you know, if you think that you know, conductive fabric and the stuff that we've seen every day that makes LEDs are interesting because it's this mashup of craft and high tech, you should see the stuff that they do with these advanced materials that have antimicrobial properties. And they just combine it, but at the end of the day, what's fascinating to us is that they still use their hands to shape it, just like somebody would you know, basically shape textiles. They have sewing machines or the same things that you would find at Michael's, but at a very different level of material shaping. I think they also don't see a lot of value. We've talked to a lot of them, and the last thing on their minds is an app for health. They, more than anybody, understand that people get better when you have actuators that work on your body. Sensors are great, monitoring is great, but at the end of the day, we get better by something that pokes us, that we swallow, or that is done to us. And an app cannot do it. So if you're and the reason I mention is we want everybody involved. We want people to think about what else we can make for them. So that's a little bit about what we use for the materials. Where are they? They're largely in small to medium institutions. A lot of the patterns that we've been seeing when we visit these institutions is that many of them, almost 90%, if not more than that, have had some sort of shock to the system. They've had some huge superstorm like Sandy or Katrina. They've had a financial shock. They've had an organizational shock. And so that means that they've had to learn to work within a non-ideal system very, very quickly. They often work in rural areas. We thought that we were going to hear more from rural areas, but not so much. But we have heard from rural areas, and the ones that distinguish themselves are those where the discharge is a lot more complex. That means that we've heard from people in Montana where the patient comes out of an operating unit, and you will probably not see that patient unless he or she is in really bad. So they have to figure out how do you discharge that patient and keep track of them, or make sure that because they're very autonomous, they're going to be okay once you say goodbye to them. So they come up with different things whereas the system is really geared towards a visit next week, or even telemedicine. Telemedicine is not going to help you in places like Alaska, where sometimes you go from 1 bar to -4 bars very, very quickly. Where are they missing? This is coming from MIT. This sort of hurt. They are largely, we know they're there, but they're not as prevalent in academic centers. We have some ideas of why, so I can't, but with the caveat that this is still a hypothesis, I think that often they see the track in an academic institution of innovation at a very, very quote-unquote advanced stage. It only happens if you have an NIH grant, or if you're doing some sort of 2-arm trial, and then there's a paper tagged at the end of it. Putting glow-in-the-dark paint on a pill bottle so that you don't have to wake the patient when you're trying to find their medicine is not something that's going to go on the New England Journal of Medicine. So you don't find those types of nurses in some of these hospitals. Same thing for large R&D systems, where you have a lot of resources, and what happens is a lot of it goes towards process innovation. This is another one of the things that people call us and say, I'm a maker nurse. I've invented a new process for discharging, and it's based on this checklist. That's great. There are many millions of dollars that go into that type of support. And that's not necessarily what we're looking for MakerNurse. And then finally, which is probably not surprising based on who might be running these types of programs, wherever you are, it's almost like we sort of brace ourselves whenever we'll read about a program that says nurse and innovation, or frankly X and innovation in general, because it's not the type of stuff that you see out there that we know is actually helping people. At the end of the day, the quintessential maker nurse does it simply because they're trying to take care of their patients and make their lives better and their patients' lives better. The last thing on their mind often is publishing, is being cool, is going to Maker Faire and showing it off, and or being cited by science or nature. So this is one of the things that we're going to have to address. Because we don't want to stay lonely in Cambridge, even though we're running the system. So let me show you some personas that we've started to develop about the different types of maker nurses. This is Victor Tai. We put him in the category of a pervasive maker nurse. These are maker nurses that were already makers when they came into nursing, so they just kind of bring that back into the unit. And he's like this Lego master builder. And what he's an oncology nurse, for instance. What he does is he makes small-scale, very realistic models of synchrotrons. These are the devices that basically pump radiation into cancer kids, pediatric cancer patients. And he shows his patients how the whole thing works. He shows them where they are, what's going to happen, so that when a 6-year-old walks into this huge device that looks like something out of a James Bond movie, they're not afraid of it. And so it's really amazing, but it's one of those things where they're already makers and they're bringing back into the unit. We've run into inventor maker nurses. This is actually one of these issues where we're going to run into lots of policy questions that I'm sure a lot of you have ideas about. The longest conversations we always have are when we get a call or an email or a tweet or a Facebook that says, I have invented something. And so this is negotiation process of, are they going to tell us what it is and how it works? And so we have to convince them that we're not going to take it from them. And oftentimes we never hear what it is, in fact. But there are nurses that successfully invent stuff and license it off, but there are many, many more that invent, and they latch on to that patent and IP system because it's their idea, and often that IP system doesn't do a whole lot of good for them. Either the hospital simply is not interested in their invention, so they finance those fees out of their own pocket and get the provisional patent and maybe a utility patent. But of course, you know, it's up in the air. If you know anything about IP, you still have to defend it if somebody infringes on. That's where a lot of the money goes in. So we know that we've heard from a lot of a handful of inventor nurses. On the other hand, sometimes we hear more, and we've read more about entrepreneur nurses. So the picture here is a product where a nurse handling IVs worked with her sister, and they made basically color-coded IVs, and then they sell them to hospitals. But they made a whole company out of it. Very simple, but that way you can sort where the IVs are coming from. There's a lot of education innovation. A lot of maker nurses are making things not so much to treat patients, but to show other nurses how to treat patients. So we've seen a lot of cool hacks coming out of like the simulation rooms, educational materials, and we have in fact seen iPhone apps. They've made like electronic dictionaries and that sort of thing. So we show them things like App Inventor, for instance. But there's a lot of potential here simply in the education space. I'm from Honduras, so this is our soccer team. But there is a concept that we found that was the team maker nurse. And it was a notion where you couldn't really pinpoint where they were or who they were part of, but they were definitely working in a very, very strong team that included doctors, nurses, nurse assistants, and other things. And that means that we have to figure out how to engage the entire group, but also highlight the role of that nurse. And then there's the indie nurse. This is the nurse that she knows she's a maker nurse. I mean, she is very, this is Roxana Reina in Corpus Christi. And as soon as MakerNurse launched, she immediately emailed and said, I'm a Maker Nurse, and let me tell you 10 different reasons why I'm a Maker Nurse. And we were definitely blown away and convinced. But she generally works on her own. You know, she runs very fast. And so the things that we're trying to address when we find indie maker nurses is how do we take that energy that you have and spread it throughout the entire hospital so we can find more of you, or you can set a good example. And then the quiet maker, I've talked a lot about people like Daniela Urbina. We're finding definitely, this is probably how Maker Nurse often started. It's the stealthiness of the whole thing. Nurses that don't necessarily tell us about their inventions. And so this is a nurse in Nicaragua, for instance, but we're finding others here in the States that hacked their own stethoscope, didn't tell anybody, and just kept on going. That makes it very hard. Then there's nurses that don't necessarily make, but help us navigate. This is Kelly Riley on the left at Maimonides. She hears about makers, and she just knows who the people are that we should reach out to the best to propel the project. So how are we engaging all of them? As I mentioned, we fly a lot. We shadow them. We create workshops in places we call expedition sites. We send pop-up meeting kits so that if we aren't able to go to places like Montana, they can hold their own meeting and then tell us the results of those meetings and make stuff. We've held Google Hangouts with some mixed results. If you have ideas of how to improve them, we would love to hear those things. We have social media, Facebook, Twitter, the whole 9 yards. It works, you know, if you're like this, join our Facebook group. We would love to hear from you. But we know that sometimes the coolest nurses are simply not on Instagram. And that's a reality that we, from working in this field 6 years ago, we knew. And then, more importantly, we have a survey. We would love for nurses or for the folks that you know to fill out this survey, because that's how we end up knowing where to go and where all these other clusters are. We make tools for them. We make tools like adherence tools. This is a toolkit so that you can make your own smart medicine bottle. We create technology crash carts. So like the name of the game in instrumentation in a hospital is a cart. So we said, what about a cart that has things like the same thing that we use to prototype in the lab? How do we launch that? And so we've given technology crash carts to Roxana and other expedition sites where they very quickly prototype. And we've launched all these things around the country. So the expedition sites are in red, and the emerging expedition sites that show some clusters are in yellow. And so they're all over the country. There's some spots where we would love to visit, but we would love to hear from them. Sometimes they make things that are very, very simple. This is simply a blanket with some tape, but it helped a baby that had this huge growth in the back basically just sit in a baby seat. That way they can go home while they're going to wait for surgery instead of being hospitalized. Sometimes they make their own little pop-up stations. So that's, on the right-hand side, that's Roxana dressing a baby with a very, very complex wound and making her own type of dressing. This is Tatiana. This is one of a team player MakerNurses, and what she was making was a respiratory device out of the same things that were in the closet. That looks like something you could buy, wasn't it, on the right-hand side? Turns out that it's basically, on the left, you see the different parts. It's a sock, it's some bandage, it's some scissors, it's Velcro, and it's some respiratory tubing that you already have access to, and it's saving hundreds of babies in the NICU in Brooklyn. This is simply a way of making a call button accessible by adding an EKG. And sometimes the stethoscopes, the tubing is brittle, and so they just, what every AV person knows, they just simply added some extra respiratory tubing to make it a little bit more durable, and you see that in the Aqua. This is a way of attaching a pacifier to a baby. This is a way of keeping babies warm during heart surgery. And this is using our Maker crash cart to make a device so that babies can actually have a effective wound drainage system. So get involved. Share about MakerNurse. Share their stories. Let us know if you think you know a MakerNurse or if you are a MakerNurse. We want to hear from you. We have limited pop-up meeting kits that we can give away so that people can make their own meetings. Help us find them, and then if you want to get involved in the design challenges that they send us, we can get you in touch so that you can work collaboratively and together. And if you find interesting tools or people or materials, go on Twitter, #MakerNurse so that we can create a movement and get these nurses out there and making. Thanks a lot.